Tonight is the third of three, and the idea of tonight's webinar is to talk about a bit more about the relationship issues that you might be experiencing and some of the stuff that might be going on in your wider life that can impact sex. So for those that haven't seen the webinars before, just to explain who I am and why I'm talking about this stuff, I'm a GP by training with a hospice background. So I've done quite a lot of work with cancer patients, and then went on to do some training in something called clinical sexology. So that's a combination of psychosexual therapeutic training, so trained as a psychosexual therapist, and then also the medicine part of that, so understanding about the biological changes and the things that happen in your body, not just at menopause, actually across the whole life cycle in men and women. But what I found in practice was that I was using it all the time in women at menopause, and then I decided to do the British Menopause Society menopause training so that I could kind of put all those skills in with what I was doing with sexology. So now my working week is kind of spread across different settings. I work in general practice. I work out of the Wilberforce Centre in Hull in a menopause and psychosex and PMDD clinic, so premenstrual dysphoric disorder, which has similar treatments to menopause treatments. I work also with voluntary organisations like the Ripon Trauma Centre and with Maggie's, working with people who've had trauma backgrounds and issues with cancer. And I also work online in a private clinic doing menopause and sexology too. And tonight, this is the third of 4 webinars I'm doing for Menopaus'ull, and we're going to look at more of the social stuff that gets in the way of sexual function. So something about what's happening with libido and how libido actually works and the way that sexual arousal works in relationships. So having a look at those things, how to work on putting yourself in situations where you feel some willingness to feel desire, which is a strange sentence, but I'm going to try and explain why I'm saying it like that. I'm going to talk about some of the problems that might happen in longer term relationships, because those of us that are in long-term relationships can sometimes find that desire changes or alters over the course of that relationship, and something about some of the sort of stereotypes around sex that might be playing in your brain and making you think that what you're doing is either not normal or needs to change. And as I've said every time, the focus of the webinars is obviously on the problems, but it doesn't mean that every woman going through menopause will have problems with sex. I sometimes find people that find that the change is quite sort of beneficial and freeing to go through menopause. And although I'm directing my language, I'm going to use the word woman a lot because it covers a lot of what we're talking about, but the information is relevant for anyone that was assigned female at birth. So this is my favorite kind of Venn diagram that explains how I've been trained to think about sexual problems. And it's the idea that you can't look at any of medicine, I don't think, in terms of thinking that if your body works then everything is fine. Most health problems are a combination of stuff that's happening in our brains and in our lives and in our bodies, but sex in particular is massively influenced by non-physical things. It's influenced by a relationship. It's hugely influenced by confidence and self-esteem and our sexual identity and the stuff that happens to us as an individual, and about things like the information that we've received about sex when we're growing up and the knowledge we have about our body and how it works, the access we have to support and healthcare around it. So there's loads of kind of cultural and social and psychological factors that influence how sex works for any one of us. So I tend to divide that and talk about different areas. And in the first webinar, we talked in detail about the changes in female bodies as they go through menopause, regardless of what age menopause happens and regardless of whether it's, a chemically induced menopause or surgically induced menopause, or whether it's happened naturally with ovarian failure at whatever age you go through menopause. But the changes that we get in the tissues of our body, in our brains, in our vulva, vagina, and bladder and pelvic floor, they're all fundamentally affected by the alteration in the hormone levels, and it changes the way that they feel and work and the way that our arousal pathways work, and it also changes our libido and our thoughts and thinking around sex sometimes. So we need to address those biological issues as best we can if we're going to get sex working again when we've run into problems. The webinar last night was based around the sort of psychological impacts of menopause. So that was much more talking about how we learn about sex and some of the incorrect messages that we might have received about sexuality that can impact how we experience it. It was about emotional well-being in terms of general anxiety and performance anxiety, mood changes, sleep changes. And we tried to do a bit about self-esteem and body image, which is often a challenge for people as they go through menopause. Part of that is aging when you're going through menopause at the sort of standard time. But there are challenges around loss of fertility, illness, and impacts of conditions like endometriosis and so on if you're going through menopause at an earlier stage. And then tonight is more about the wider world and our relationship. And it's the one that I find hardest to give a standard approach to, because this is the stuff that's incredibly personalized to your experiences, the world around you, your partner, the dynamic within that relationship, or if you're dating, your feelings around that, and the sort of, for want of a better word, the baggage that we bring with us when we're going into new relationships. So I'm going to talk a little bit about the demographic of menopausal women and the issues that are impacting them, a little bit around issues in relationships, something about arousal and libido, and things like that tonight. So I'll try and cover as much as I can. I think one of the things that is worth mentioning is that menopausal women these days are quite different to how menopausal women looked as a demographic maybe 30, 40, 50 years ago. I know that many of our mothers didn't talk much about menopause as they went through it, and we're, I think, thankfully being quite a lot more vocal. But I think the demands on us as women at this stage in our lives are very different now, or certainly have intensified. And we've got studies that show that and support that sort of idea that things are more difficult now. We tend to have our children later in our lives than we did. So many of the women that I see in clinic are still dealing with quite young children. I even get women who are still breastfeeding as they get the changes of their perimenopause starting. There's a lot of difference in whether people are in long-term relationships or have gone through divorce. More of us go through divorce these days than perhaps 30, 40 years ago. So new relationships and the challenges of new relationships in this age group are more relevant. Women's demands on time are also greater. So many more of us are working and working in increasingly busy and pressured jobs. The crossover with jobs to home is different these days with social media and our phones, and the fact that, you know, for me, emails hit all day when I'm cooking dinner and when I'm looking after children and running around. And that sort of feeling of pressure and having to be on it can be incredibly stressful, gives us less downtime and makes us feel more chaotic, I think, at times. Our children often hit puberty at the same time as we go through menopause, and that can feel quite strange, looking at somebody embarking on relationships in that part of their lives and sort of in the first bloom of youth at the same time as we're experiencing changes in our bodies and our sexual function. And we know that across all of female sexual problems, the factor that makes the biggest difference in terms of when you're filling in what we have, which are called sexual function scores or sexual satisfaction score questionnaires, the impact is biggest from our partner's health above and beyond anything else that might impact our sexuality. So that includes our own health, menopause, stress and other things. It's our partner's health that has a big impact. So that's one of the ways in which the sort of social factors can be really important in our sexuality. And if you're going through an early menopause, there's challenges that are attached to that as well. There's it's a big adjustment to make if you lose your fertility early, particularly if you didn't have the family that you planned. There's a grieving process that goes on with that. Some people will have lost their fertility as a result of illness, and that again can be an enormous adjustment process, not just to the sort of physical changes, but there's a psychological adjustment that needs to happen when your body has behaved in a way that's been challenging. And I find people grieve for what they should have had, and there's a real sort of adjustment that needs to happen to where we find ourselves. And that psychological impact and the impact within our relationship can be quite significant and can impact how sex works. And as I was just saying before we started to Lucy, you know, the demographic that we're in, we are in the sandwich demographic. We are stuck between looking after parents that are living longer and living to have multiple conditions that need care. And most of the caring burden still falls on women, particularly women at menopausal age. Our children often have lots of demands and things that they need at this age as well. Many of us are working. We are running around like crazy. We're distracted, we're busy. Having time to care for our needs, our basic sort of needs of eating properly and doing the things that we're supposed to do, let alone our emotional needs and our sexual needs, it can get really pushed onto one side. And that is certainly something that I think challenges people with their sexuality at this stage of life. And read a really lovely book about psychological challenges that said that the most psychologically challenging period in our lives is our 40s. It's more psychologically challenging than your teens, but I don't think any of us know any teenager that has got to balance as many challenges as we are balancing and has this many people relying on them as we do. And I don't think it's a shock to find that the impact of menopause in terms of your sleep, your feeling of mental capability, word finding, coping skills, stress levels, sleep levels, all of those things create this perfect storm, which means that going through your menopause transition and midlife in particular is an incredibly challenging time. And the suicide stats for women reflect this. The peak rate for suicide in women is in the last part of our 40s. So these sort of psychological and social challenges are really very real. And it's not looking at the picture properly to only focus on, testosterone or estrogen to the vulva and the vagina. If you want to try and improve sexuality, you have to kind of go wider to the whole world that's behind the woman that we're talking to. So sexual relationships, my challenge is how to talk about how menopause can impact those. So what I say often when I'm talking about sex is that sexual function or our sexuality is built on these 4 basic pillars that have to be working pretty well for us to have a healthy sexuality. So we need the bits of our body that coordinate sexual function to work well. So the nerves, the blood vessels, genital tissue, brain, all that stuff has to be working. Obviously, menopause impacts that. We need our wider body to be working well as well. So we need to be well, not on medication, not feeling pain, not struggling with joint problems, able to use our senses to enjoy sex. And again, those sort of physical things can impact sex. We talked about sexual identity in the last webinar that I did, which is the concept of who we are and who we are sexually and our sexual identity. And tonight it's sexual relationship. This is about not just who we express our sexuality with, but who we're actually able to express it with. We don't get to always express it with who we might choose. We make commitments to be in long-term relationships, and that can have its own challenges. And it's difficult sometimes to negotiate our sexuality in partnership. So when I'm talking about sexual relationships, I guess one thing that I often press upon other doctors when I'm teaching them is that just because somebody isn't in a relationship doesn't mean that sex isn't important to them. I think of solo sexuality as being as important as partnered sexuality, and for many women the two things run alongside each other. Not every woman engages in solo sex, but lots do. And just because we're not partnered as we go through menopause, it doesn't mean that we're prepared to kiss goodbye to that side of our identity. So it's sometimes useful as well to compare what's happening in solo sexuality to what's happening in partnered sex, because in partnered sex there's a lot of challenge in sort of bringing our sexuality, which might have its own little flaws and function problems, alongside somebody else's and trying to make the whole thing work properly. So when we start to do work with couples about improving sex, one of the focuses that we tend to have is initially on what happens on your own. I've heard it described that good sex is like 2 musicians playing separate instruments but managing to harmonize, and it's a bit like that. If you've got somebody that, if you've got a heterosexual relationship and you've got a male partner who's got erectile dysfunction problems and is worried about losing his erection, and then you're trying to coordinate that with a menopausal woman who is struggling with arousal and climax, that challenge of the two of you together is an additional challenge compared to you just working on your own and taking all the time you need to get into the right zone and maybe using toys or intensifying sensations. So there are different challenges in partnered sex, and it's sometimes worth sort of recognizing the additional level of difficulty that can create. And it creates performance anxiety in one or both partners, which isn't present in solo sex usually. So knowing that, and lots of women that I talk to think that they're too slow at getting aroused and too slow at reaching orgasm. So sometimes just busting that myth with couples is really important, and widening the goals of sex so that it doesn't become just orgasm for a male partner or orgasm for both of you being essential each time. There can be anxiety around pain with penetration that isn't present in solo sex, and there can definitely be sexual boredom or typecasting that happens in long-term relationships. I touched on this last night, which is that most established couples have figured out each other's bodies to an extent, and sex tends to fall into a pattern. It can be described as sort of a A to B to C or a 3-course meal. Everything happens in a set direction often. And that can mean that there's a lack of novelty, which can become less arousing. And it can also mean it's more difficult to introduce new things when you've been doing things the same way for a long time. So there are particular challenges with that. And as I mentioned before, whether or not you're in a same-sex relationship or in a heterosexual relationship or in a different relationship formation, both bodies, male and female bodies, experience changes in sex as we get older. So touch sensitivity decreases. It can take longer to become aroused. It can take longer to reach orgasm. Penetration, so male partners have more erectile problems as age goes up and other health issues get involved. Premature ejaculation can become a bigger problem. Certain medications in male bodies, like antidepressants, can mean that delayed ejaculation or inability to climax can become a real issue. And if you've got two females in a partnership together, that can be particularly challenging if both partners are going through the same changes at the same time. And when we end up with a situation where one partner's desire for sex or need for sex is different to the others, and there's no normal. I think the NatSal study said that the average number of times people have sex per week is 2, I think, from memory. But there's a massive variation in couples between, what sort of level of sex would be deemed acceptable. But we do know that relationships struggle when there is a difference between the amount of sex that one partner wants and the amount of sex that another partner wants, particularly if there's an expectation that all sexual desire has to lead to partnered sex rather than it being acceptable for that to be solo sex. And I find that lots of couples, when sex has become a problem, it's like the elephant in the room. And especially if everything else is okay about the relationship, it can be incredibly challenging to talk about the thing that's not going right because you really value the other aspects of the relationship. And I find that couples sort of dance around this problem. So they go to bed at different times. One of them will take a laptop up and do work, and the other one will stay downstairs. People avoid date nights. They won't even hold hands or cuddle in the kitchen because the partner that's avoiding sex or is worried about sex for some reason is often fearful that any kind of intimacy or affection might be seen as a green light. And so therefore they don't want to give a green light because they definitely don't want to have full penetrative sex. So everybody sort of avoids, and all intimacy can disappear within a relationship. And that, if you're on the other side of that and you don't understand what's leading to that and the reasons why all intimacy has gone away, it can feel like a rejection of love rather than just of sexual function. So we're going to talk a bit about love languages, but sometimes the most important thing that I do in a room with a couple is get them to both name what's going on and to explain it from their perspective as to how they're experiencing it, and almost sort of break that silence, which can hugely help. So in terms of long-term relationships, the lady that's written about this most extensively, Anne, has got really good books I often recommend that patients look at. And she does great TED Talks, and she's got, podcasts and all sorts of things, is Esther Perel. And she's a relationship therapist who has done a lot of work on what happens to desire in long-term relationships. And she's got this sort of concept that we need 2 different things, and those 2 different things can make it very difficult in a long-term relationship to keep sexual heat going. So we have a real need for intimacy and knowing our partner and being accepted and having that closeness and oneness of fully knowing the other. And that allows us to feel a lot of companionate love and a lot of security and safety and attachment. But sexuality and sexual function and desire is at its greatest when we don't know something fully. So in the early stages of relationship, when we're learning about the other person and we're kind of experimenting and wanting to find out more about them, desire thrives. And it's 2 different sort of sets of wiring that means that often it's very difficult for the 2 things to coexist. And the desire that we feel early in a relationship is really chemically driven. When we have an orgasm, we release a chemical called oxytocin, which is a bonding chemical. We release vasopressin. They've done experiments where they've injected that into birds, and the birds go on to sing mating songs because it kind of creates this bonding behavior. And when we have a rewarding bit of intimacy, whether it's sexual or just sort of touch related with hugs or eye contact, even basic things, we release these chemicals. we get a hit of dopamine. Dopamine makes us happy, and we get wired to our partners. And for a couple of years, really, it's that kind of ties us to our partners and makes us feel almost physically addicted to them. And it is the same as the addiction cycles that we have for other chemicals. But after that point, because the more we know something, the hit of dopamine you get from something new reduces over time. It's why people need increasing amounts of alcohol or drugs or whatever that the other hit is when they get addiction, that the hit of that dopamine reduces over time. And to an extent, there's an element of that in long-term relationships, and that sort of desire drops a bit, but intimacy and love and companionship and building a world around us kind of increases. And so one of the paradoxes is, what do we do if we need both of those things? What do we do if we want that closeness and companionship and safety and security, but we're missing the heat of desire? And the sort of feeling that we need novelty is proven even in studies. So if a man has a heart attack, and if he has his first sexual experience after the heart attack with a new sexual partner, he is more likely to die because the physiological impact of having sex is greater, it's more exciting than if he has it with an existing sexual partner. Men release more sperm, they have a greater semen volume, they have more sort of blood pressure increase with a new partner versus an existing partner. And the science supports the same thing in women too. So whether or not this is convenient for us in the way that we design our lives and the sort of expectations we have socially around our lives, this is what we're wired to. And it's useful to recognize it and then to do something with that within a relationship to try and help you to keep some space and some novelty. I think I talked about this last night, but there's this idea of the erotic equation, which is that if we have strong attraction to something, but it's not easy to get it, it increases our want for that thing. We anticipate it, we think about it, and we get a bigger hit when we finally get it. So one of the ways that it is recommended to try and work with this in a long-term relationship where desire has become more difficult is to allow space for each individual to grow and to change. So when we merge completely, we know too much almost about the other person, and we often find our partners most attractive when we see them from a distance. If you watch them across a room at a party, or if you see them working, you'll often get more of a hit of the things that drew you to them in the first place, because you can see them at a distance than you do when you're seeing them night and day in the shower, leaving their pants on the floor, doing all the things that drive most of us mad. So one of the ways that we try to sort of help people to get around this from a couples therapy perspective is to encourage couples to create a little bit of space and a little bit of unknown in a safe way within the relationship. So looking at the things that you might want to do to nurture yourself as an individual, spending a little bit of time away and then actively coming together again afterwards to reconnect and learn about the other helps to drive a bit of that curiosity. So this is like date nights, but going further, really, the idea of having catch-up time and time where you find out what the other person has been doing and thinking about, and that unknown helps to drive that little bit of curiosity and intimacy. And I think the other thing that couples need to do is actively plan for this sort of thing. We all grow up with the spontaneity myth. Early in a relationship, there's lots of passion. It's difficult to keep your hands off each other, but that becomes less pressing for many couples over time. And we see in films that sex is always portrayed as being high passion and spontaneous, and you can't keep your hands off each other and tearing clothes off. But in reality, that's not what happens in longer term relationships. And I think it's important to think of all intimacy, not just penetrative sex, but all intimacy as something that's high value to both of you. And if it's high value, then it's worth planning for and actively diarying in time, not just for penetrative sex, but for any sort of intimacy and closeness, and getting into a habit of prioritizing that and planning it and diarying it helps to make time for it, but it also helps to keep the wiring going. Each time we have a successful sexual encounter, or we have an intimacy, if we had a close emotional moment and it goes well, we release the chemicals, the dopamine, the oxytocin, the vasopressin, that wires us back to doing that again. So when we don't do it for long periods of time, it actually gets more difficult to sort of rekindle that. So it's quite important to keep throwing a log on the fire, so to speak, and keep those hormones flowing. And you can actively plan for that in a relationship. How do you do this? How do you start to talk about this with a partner without offending them? Well, one of the tips that we use therapeutically is to make sure that any communication that you use speaks about how you feel rather than what you might want from a partner. So it's better to say, you know, I used to love it when we, or I remember this thing and it was something that I used to really value and I'd like to do it more. Or to draw attention to something that you feel. So, you know, I love it when you kiss my neck. I love it when we have time together, and I love it when we have a massage, is much better than saying, you never want to massage me anymore. You know, you never do that thing that I really enjoy. So phrasing it in a way that's about you is much more likely to be met with a good response where the person feels that something they've done is valued, rather than to be met with a defensive response. I often say it's like taking the bins out. If I say to a partner, you know, you never take the bins out, it's really different to, oh, I'm so grateful when you do that. It just encourages a different response. And you can actively work on those bonding hormones with non-sexual touch. So for those couples that have separated completely within the house and everything that they're doing is operational, it's about getting the kids together and sorting the house out and doing all the sort of the practical stuff, but they've lost a lot of intimacy, starting with basics. So there's a technique called hugging till relaxed, where if you stand with your sort of centered on your center of gravity on your feet, and you hug so that you're neither of you are leaning in and relying on the other one too much, but you're actually sort of holding your own space. And if you stay in that until your muscles all relax in, at that point you start to release oxytocin, and that oxytocin again triggers your hormones to sort of bond you. Oxytocin is the breastfeeding hormone that bonds us to our babies, and it's released by orgasm, but it's also released by hugging till relaxed. It's released by prolonged eye contact. And in couples work, we often use Sensate Focus, which is a program of non-sexual touch that gets couples to reconnect again. Starts with, you know, arms, legs, limbs, heads, moves towards upper body touch, but not genital touch. And eventually it moves towards genital touch and penetration. But it's built up in layers with the idea that it's getting the chemicals going, it's taking the pressure and the goal focus off sex, so that you're having intimacy for intimacy's sake rather than because it's got to lead to penetration and an orgasm. And then the other thing is sexual currency, which is sexual currency is like talking about food rather than eating food, is the best analogy that I can give. So when you're actually having sex, it's a little bit like the time where you're actually having a meal, but sexual currency is talking with your partner about things that you've enjoyed in the past, things that you've done together, things that you'd like to do together. It's that flirtiness that's there in the beginning of a relationship that falls away over time, and you can start to try and reintroduce that, and that can help you to reconnect again. Dating is a whole new ball game, and although you have the advantage of novelty, and so you've got all those nice early chemicals that help you to feel desire and get bonded, there are the disadvantages of all the kind of sexual scripts that exist that tell us what sex should look like, or ways that you should be able to orgasm or enjoy things. And actually, in reality, many people's bodies don't work like that, even at their sort of best and healthiest in their 20s and 30s. But by the time we reach menopause and there are some challenges with how we're working physically, we can have real issues with feeling a pressure to look like we're responding or look like we're enjoying something, and actually not really feeling it. And then it's very difficult to backtrack from that place. So it can feel really hard to communicate in a new relationship. Lots of people can feel shame and a sense that they should be more sexual, they should be finding things more enjoyable. But it's really important to not get shoehorned into an idea of shoulds with sex. Sex at its best is an incredibly individualized, you know, we talk about an erotic palette, this idea that there's loads of different things that most of us are interested in sexually, and there'll be loads of different things that a partner is interested in sexually. And then there are little areas where it overlaps. And one of the things about that sexual currency talk, where we start to flirt and talk about what we like and what we'd enjoy, is it gives us a chance to try safely, often with a new partner, to explore where interests might overlap and to be more honest about those things. The communication is incredibly important. Lots of sex happens because it happens. You know, people just try things out and it either goes well or it goes badly. But talking more about it can be really important, particularly in a new relationship. And I touched on these numbers last night because I think they're really important. There's a massive gap between the orgasm rate of men and women, particularly in hookup sex, so sex with a new partner. So men and women left on their own to touch themselves can mostly climax within minutes. So about 95% of men, 95% of women can climax it because we know where to touch and how long for and with what pressure and, you know, in what ways to make that happen. in partnered sex in a long-term relationship, it's 95% for men versus 65% orgasm rate for women in a heterosexual relationship. This drops to 18% with a new partner in hookup sex. And if we're not careful about it, talking to a new partner about the fact that that's happening, we can get stuck with that. So it's really important to kind of to name it so that I think women understand that this is something that is happening across the board. But in female sex, the orgasm rate is 85%. So women's bodies are not the issue here. It's the expectations of the kind of touch and the kind of sex that leads to orgasm, which is the problem, rather than women's bodies themselves. So I think lots of women feel that their orgasms are difficult, or they take too long, or you need sort of unusual touch rather than the kind of touch that's just a standard part of sex in order to orgasm. And we have language that doesn't help us. We talk about foreplay versus sex as if foreplay is optional and sex is the main event. And again, I want to kind of loosen that up a little bit and just normalize the fact that if you're finding it difficult to climax through penetrative sex, it's incredibly normal. That's what most women find. So just the stats on this kind of thing. There's not many studies on this, but there were studies done by Masters and Johnson back in the 50s. They had a love lab, and they looked at couples together, and they said that about 30% of women can climax through penetrative sex, so just through that alone. But actually, when you look at the figures, they didn't exclude the women that were stimulating the clitoris on the outside at the same time. So the number of female bodies that are actually able to climax only through penetration is much lower. If you look at the ways that women engage in solo sex, less than 3% of women will only use penetration if they're pleasuring themselves. They might use it as part of external stimulation, but they certainly won't, not many will do that on its own. So the vast majority of women need clitoral stimulation directly to have an orgasm, particularly as we get older and we get a little bit less responsive. Yet about 2/3 of women are regularly faking orgasm because we've got loads of pressure on us to look like we're having a good time. And I've listed some of the reasons, one of which is just wanting sex to end. It signals the end of sex. And I think one of the reasons that, and I hear this a lot actually, that women's kind of like, I'm still going, and I'm bored, and I got bored 5 minutes ago. So I think some women will fake an orgasm because they just want to say, okay, that's the end of it. They haven't had a particularly exciting time. I think it helps us to feel like a good sexual partner. So often I think if we look really sexual, it makes us feel like we're good at sex, and that might help us to keep a partner. Sometimes it's to avoid conflict, or because we feel that something is wrong with us if we can't. But actually, it's just important, again, to name it, to say this happens a lot. And if you think about this, then it's no wonder that many people's desire falls away if sex is not rewarding in that way. And statistically, the likeliest way for female-bodied individuals to orgasm, commonest way is with your own fingers or a toy. Second commonest way is with partner's fingers or a toy. Third is oral sex, and the lowest of all is with penetrative sex. So that's how bodies are designed to work, and we need to sort of build that into what's happening with sex. So one of the myths that I come up against is that men are ever ready, and just flick a switch and they're ready to go, and that isn't always the case for all men, and that in itself can produce pressures within relationships. And with women, that it's some incredibly complex set of wiring, and all the situation has to be right, and everything has to be going in the right direction. And again, that's not how all women experience their sexuality. And if you're looking at libido and initiation of sex, society's changed. We used to think that men were the main initiators of sex within heterosexual relationships, but actually it's getting a bit more 50-50 now, as women are starting to talk a bit more about their sexuality. But libido, lots of women come to see me in clinic and say they've lost their libido, and I think what they mean when they say that is they've lost their innate desire for sex. So I often describe libido as being a bit like hunger, in that sometimes when we eat purely because we're starving and we have a real urge to eat, and we need to do it. But most of the time there's a whole bunch of other reasons that we eat, just in the same way as there's a whole other bunch of reasons why we have sex. So we eat because somebody else is eating and it looks good and we think we want to join in, or we eat because it's time to eat and somebody expects us to. We eat because there's an occasion to do so, like a date night, so someone's set you a meal and taking you out somewhere, there's an expectation. Sometimes we don't know that we're hungry until we start eating, or we'll see something that looks particularly delicious and we'll do it just for the pure pleasure. And sex is a bit like that with libido. There's an element of sex that's like an itch that needs scratching, and that's kind of what libido is. But a lot of our sexuality happens because of lots of other social and psychological factors that help us to sort of be encouraged into sexual activity. So we often talk about the biological things that impact libido, which is your testosterone levels, your estrogen levels, medications, and so on. I have been known to ask the Hugh Jackman question, which is, if I could prescribe you a week in the Maldives and Hugh Jackman, would you fancy having sex? Or is it more to do with the kind of sex that's on offer for you? Or is it because other people are interrupting or distracting you, so you're too busy, there's no privacy? And all those things will impact on desire for sex too. And testosterone is something that I get asked about a lot, and I've just brought it up even though we're not doing about biology as such tonight, because it's an intrinsic part of people's questions around libido. Yes, it's important in terms of our sexuality. Yes, it's important in the imagery, our dreaming, our fantasies, our thoughts about, sort of spontaneous thoughts about sex. We make it in our adrenals and our ovaries, and we lose it over time as we get older and our ovaries stop making as much of it. Women who go through treatments that either remove or damage their ovaries have significant loss of testosterone, and almost always will benefit from testosterone being given back. But it doesn't solve all libido issues. And I certainly find a mismatch between the women that ask for it and hope it's going to fix everything, and the reality, which is that it's often to do with how the relationship is, expectations, how they feel in themselves. And it's that's the bigger problem. So when we're unpicking why desire for sex has gone away, it's really important to work out sort of what was the first thing that was happening. When was the last time that it was okay? What seems to be getting in the way? Is it something wrong with how you're getting aroused? Is there something wrong with the fact that sex is perhaps painful? Is something else going on? And people have studied arousal and how it works, and I think it's useful to look at this when we're talking about the social stuff with sex, because one of the most important models for looking at longer term relationships and desire in women in the sort of menopause demographic is that desire often doesn't work as easily in female bodies as it perhaps does in male bodies who have slightly higher testosterone levels and slightly higher innate sort of spontaneous desire. So not everybody will fit into one box. It's useful sometimes to think about what model of desire fits you. So this is, I mean, it's a chart that you shouldn't get too sort of over sort of worried about looking at, but basically the idea when desire was explained for the first time, or what happened in sex was described for the first time, is that we're on baseline, we're not interested in sex at all, and then we get aroused and our sort of sexual interest increases and our sexual arousal increases. We reach a plateau. At some point we might orgasm. Women get to orgasm multiple times if they're lucky, whereas men tend to get one orgasm and then hit this next phase, which is resolution, where you can't actually get them excited again. Sometimes just for seconds or minutes, but as men get older, that can go on to days actually before they can achieve another erection and get aroused again. But for women, we can orgasm multiple times if we're lucky, and then we go into that resolution phase where everything's a bit numb, and even with lots of stimulation, it's difficult to kind of get off the starting blocks again. Another sex scientist came along and said, well, hang on a minute, we need to have desire before this. So this sort of idea that you need to want to be aroused before you can become aroused started to get spoken about. But the model that I think is most relevant for most of the people that I speak to is a circular model by a lady called Rosemary Basson, who said that actually there's lots of other reasons that we have sex other than desire, and we need to recognize this if we're going to try and increase desire again. There's loads of words on this slide, and I'm mindful of not getting too sort of sciencey with it, but the essence of this model is that sometimes we have sex because we have spontaneous desire, but often we have sex because we respond to something. And spontaneous desire is something that there's loads of in the beginning of a relationship, but responsive desire becomes much more prevalent as we're in a longer term relationship. And she described that we're basically sexually neutral. We're sort of sitting around, might be interested in sex, might not be. If the right set of things happen, and if we're willing, then we're able to get into that circle and access our sexual response. But sometimes we're not willing, and I'll talk a bit about that afterwards. So you need willingness, you need the right stimulus, and you need some kind of motivation to have sex. So some of the motivations that they talk about are what we call approach motivations. So these are positive reasons we might want to have sex. So because it doesn't have to be an orgasm, but it might be that we feel closer to our partner, or more in love afterwards, or we feel relaxed and we can go to sleep when we have sex, or sometimes just want the physical pleasure of it or to express love. A lot of women are motivated by avoidance motivations, so a desire to stop something happening, like a partner leaving, or somebody falling out of love with you, or wanting someone else instead. So that might be the motivation that drives you to respond to some sort of sexual stimulus. And sexual stimulus can come in all kinds of forms. So these are all the turn-ons. This might be touch, it might be smell, it might be a memory of something, it might be music, or someone's aftershave, or a certain kind of memory of something that can kind of, watching something that can trigger something for you. But at some point there'll be like a spark, and if you're willing and if you've got the right motivations, then you will enter your kind of sexual arousal cycle. And I think looking at it like that can be really helpful, because I find that people expect this to sort of fall from the sky and they're just going to get this spontaneous urge. And actually, a lot of sexual encounters happen because we put ourselves in situations where it might happen, or we do things to make ourselves more likely to be exposed to things that might get us in the mood. And understanding that is quite important. And I think it's also important to understand that many of us aren't sexually neutral. We're kind of sexually averse. We're cross with our partners sometimes, or the last time we had sex, it really hurt and we don't want to do that again. Or we don't feel sexy. You know, this is the stuff that we talked about last night. But if you're feeling that your body's changed and you're finding it hard to find yourself attractive in that, then you're not just neutral in sex, you're kind of not really wanting it. So tackling these things first can be really important too, including the physical things like flushes and sweating. And this really, really busy, and there's not a nice, easy way of describing this, but all that this is trying to say is that you can get into positive spirals. So in this one, you've got either your spontaneous desire, or you've kind of kicked in with someone might have touched, and that touch might feel good, and then your desire kicks in. If something good happens on the back of that, sex goes well, you feel close to your partner, you feel bonded, then next time round, you're more likely for that stimulus to make you want to have sex. In this one, if something bad happens when you engage in sex and you feel upset, ashamed, you have pain, something doesn't happen, there's a problem, next time you get that same stimulus, you're much more likely to want to get into things. So you can get into a negative cycle. So we've got to look at, one of my things that I do in my job is to kind of unpick all of this and try and work out what's going on and where I can tweak and change things to make it a bit better. And then there's love languages. And the only reason for talking about love languages is I get to see both partners sometimes in Wilberforce. Sometimes people will bring their male partner with them or female partner with them. And when we open the conversation up, it's astonishing sometimes how the partner is feeling when sex has become a problem. And one of the ways that I explain to people why this can happen is that we all have different ways of showing that we love somebody. And there's a concept of love languages, that there's 5 main ways that we can show our love. And most of us use 1 or 2 of these ways with our partners to sort of demonstrate that we are still in love with them and we value them. And these are described as acts of service, which is kind of doing things for them, making dinner, tidying up, giving them things that they like. Quality time, which is, as it says on the tin, giving them your time and attention. Some of us use words and we tell people that we love them a lot and we tell them how wonderful we think they are, and that's the main way that we show it. Some give gifts and some use touch. And if your love language is not the same as your partner's, and if your partner's main love language is touch, and I think for many male individuals, sometimes sexual touch and intimacy is the only legitimate way that they've got of being held and cuddled and nurtured, the absence of all of that can feel like love is being rejected, not just that sex is gone. So I think, again, sometimes looking at this as a couple, thinking about the ways that you express emotions and that connection between the two of you can be really important. And naming it and introducing some touch that isn't perhaps sexual, but actually rekindles that sort of message between the two of you can be really important. I often spend lots of time saying that all sex is not penetration. It's not the only thing that sex is. It's a buffet. There's all sorts of stuff that you can do that counts as sex. And actually what you need to do is widen expectations, take goals away, make all of it count. And that's often the route into things being better. So we're back nearly at the end. This is just a slide that I've shown in all of the webinars, because I think, when you're looking at stuff that's going on, it can be really useful to come back to this kind of conditions for good sex analogy. So sitting down on your own and thinking about the times in the past when sex has been at its best and hottest or most exciting for you, and then working out what was going right then, what might not be the same now, and what you might be able to do to get back to where you were, can be incredibly important. And this is something that Karen Gurney, who's written a really good book called Mind the Gap, talks about, and I find it one of the most useful exercises to give individuals or couples who can't go to sex therapy, can't afford to have 10 or 15 sessions one-on-one with somebody, doing this sort of exercise, working out psychologically what do you need to feel most turned on, most in the moment, most sort of primed to be sexually responsive. Do you need to have had all of the jobs done for the day and have had an hour and a half on your own to get yourself ready so that you feel in the right zone, physically and emotionally, to be intimate with somebody? Do you need your partner to have done certain things so that you're open to sex? Do they need to have met your emotional needs and done some of the jobs around the house first? Do you need to wear certain things so that you feel sexy and you feel good about yourself? When do you feel at your best with your body as it is now? The physical stuff is all to do with looking at the changes that your body's been through, optimizing medications, thinking about HRT, thinking about topical estrogens to make the vagina and vulva work as well as they can do, lubricate as well as they can do. And it's also about mapping your body and understanding how it works now and what you like best now. What kind of touch, where, what pressure? Do you need a toy? Do you prefer vibration, a clitoral sucker, something different? What touch in other parts of your body makes you feel more primed for this? And the bit that is so important is being mindful during sex, staying mentally present during sex. So how do you come out of your head? Or sometimes women are sort of halfway across the room making lists and thinking about all sorts of things. How do you bring yourself back into your body during sex so that you can notice sensation? How do you connect in with your sensory input, which is what's going to put the accelerators and get your sexual response going? So this is staying mindful. It's learning to focus on touch, sound, sight, smells, the sort of the visuals, and getting yourself so that you are in your body and really connected with what's going on. And it's this that kind of gives us what we sometimes talk about as good enough sexuality. It may not be quite, everything may not work quite as well as it did when you were 25, but if you're able to access these things, you will have good intimacy that will leave you feeling rewarded. This is the list of useful books and sites and options for referral that exist. And then I can take questions. Thank you.